Hello everyone. In this presentation we're going to look at the third part of the cranial nerves, which is going to be the Pons Division. In this division we are going to learn about other nerves that are originating from Pons, and we're going to look in the coming slides about that. So the nerves that originate from the Pons, there are four of them. One of them is cranial nerve number 4, which is the trigeminal nerve. Number 5, which is a trigeminal nerve. Number 6, which is the abducens nerve. Number 7, the facial nerve. And number 8, the vestibulocochlear nerve. And we are going to look at each nerve individually, its pathway, innervations, and the clinical relevance as well as we proceed. Let's start with the trigeminal nerve, which is the cranial nerve number 5. In these two pictures, you will see the distribution of the trigeminal nerve. So in this nerve, we have three main branches. The first one is the ophthalmic branch, or the ophthalmic nerve, which is the V1. We have the maxillary nerve, V2, and we have the mandibular nerve, which is V3. The ophthalmic part of the trigeminal nerve, the V1, it exits the skulls via the superior orbital fissure. The maxillary one exits the skulls via the foramen rotundum, and the V3 or the mandibular one exits the skulls via the foramen ovale. Trigeminal nerve has both the sensory and the motor functionality. It has the general somatic efferent and the afferent innervation to the facial structures. So let's look at the branches in this diagrams right here. This is V1, V2, and V3. The V1 portion supplies 4%, V2 portion supplies 35%, and V3 comes the 30%. So let's discuss these branches in detail. First one is the ophthalmic nerve, V1. It is a general somatic afferent branch of the trigeminal nerves. So it provides the innervation to the eyes, conjunctiva, upper eyelids, orbital contents, frontal sinus, ethmoid air cells. It has nasal dorsum, anterior scalp, anterior aspect of the dura mater, the cranial fossa, and the portion of the tentorium cerebelli. If you remember the cerebellum and the meninges, you'll understand the tentorium cerebelli. The second one is the maxillary division. It is a general somatic afferent branch of the trigeminal nerve as well, and it provides the innervation to the nasopharynx, nasal cavity, palate, maxillary teeth, maxillary sinus, skin from the lower eyelids, gums of the upper jaw, tonsils, and dura mater in the middle cranial fossa. And it also provides the autonomic innervation to the lacrimal glands and the nasal glands. Next, we have the mandibular division of the trigeminal nerve, and this one provides both sensory and the motor innervation. So the sensory innervation is to the skin of the lower lip, anterior external ear and portion of the external acoustic meatus, temporal fossa, anterior 2/3 of the tongue. This is important, you have to remember that. Anterior 2/3 of the tongue, mandibular teeth, mastoid air cells, mucous membranes of the cheeks, mandible, gums of the lower jaw, and the dura mater of the middle cranial fossa. Now the motor distribution of the mandibular division includes the muscles of mastication, and these include temporalis, masseter, lateral pterygoid, medial pterygoid, and the other muscles that get the innervation from the mandibular division of the trigeminal nerves is tensor tympani, tensor veli palatini, anterior portion of the digastric mylohyoid. Now we're going to look some clinical considerations, some clinical relevance of the trigeminal nerve. So depend on where the damage is occurring, the trigeminal nerve will cause loss of sensation that includes any branch, or it will cause the impaired chewing. The very first one, and this is the high yield point of this nerve or the clinical consideration, the very first one is the herpes zoster ophthalmicus. As the name suggests, herpes zoster is the herpes zoster virus, and ophthalmicus means the ophthalmic branch of the trigeminal nerve is involved. So it is an emergent condition which usually involves the ophthalmic branch of the trigeminal nerve caused by the herpes zoster virus. And why is it emergent? Because there is a associated risk of blindness, and there is pain, and note the redness of the conjunctivitis. It is important. So if you look at this diagram, this is the V1 division or the ophthalmic branch of the trigeminal nerve that you see. You see all this redness all over the place. This is the distribution of the V1. So when the herpes zoster virus affects the ophthalmic branch of the trigeminal nerve, it will cause the herpes zoster ophthalmicus. The second one, which is also a high yield point, is the tic douloureux or the trigeminal neuralgia. So trigeminal neuralgia is the pain in the region supplied by the involved branch of the trigeminal nerve. The causes for this one is basically the compression of the trigeminal nerve by the superior cerebellar artery, and this is the most common cause. Other causes involve the tumor, aneurysm, or infarct. The ophthalmic branch is rarely involved. So how does the artery is involved in this disease process? The artery that is involved in this disease contribute to it by pressing against the nerve, and the pulsation from the artery can wear away the myelin sheet, causing the demyelination. So for example, this is the axon and this is the myelin sheet going on, and there is an artery going on there. If there is a aneurysm or something and the artery is pressing on this myelin sheet, it will cause the demyelination. Now the next nerve that we're going to discuss is the abducens nerve, which is the cranial nerve number 6. The functional component of this nerve is that it is a general somatic efferent nerve, and it exits the skull via the superior orbital fissure. It innervates the lateral rectus muscle, hence it is involved in the abduction of the eyes. Clinical consideration. So let's look at damage to the abducens nerve will cause the impairment of the lateral rotation of the eye. So basically eyes are unable to abduct, hence the eyes will deviate medially at rest. So you look at this image right here, the finger is being moved on both sides. So you will see that the affected eye is unable to abduct beyond the midline. So this eye right here is basically affected. So I'm assuming that the physician is moving the finger this way. So you see this eye, which is correct, is able to abduct this way, but this eye is unable to. What are the causes? The major causes for these pathologies include, of course, tumor is most important, infarction, and aneurysm of the neighboring arteries, which will put pressure on the abducens nerve. This is one of the important causes that will have the palsy of the abducens nerve. Now we're going to move on to the next one, which is the cranial nerve number 7, or the facial nerve. The major branches of the facial nerve innervates the different regions of the face. So that started from superior and goes to inferior portion of the face, and that includes zygomatic branch, buccal branch, mandibular, and cervical. So facial nerve exit the skull via the stylomastoid foramen and internal auditory meatus. Functional component, there are 4 functional components of the facial nerve, and that include the general somatic afferent, special afferent, general visceral efferent, and the branchial efferent or motor branches, which basically provide the innervation to the muscles of the second pharyngeal arch during the embryonic development. So we are going to look into each one of them in details now. So the first one is the general somatic afferent. So this branch provides the innervation to the external acoustic meatus and the deeper part of the auricle. Pretty simple. Special afferent, this branch has both the sensory and the parasympathetic functions and provides innervation to the sense of taste to the anterior 2/3, which is again important, of the tongue, coda tympani branch of the facial nerve. Number 3, general visceral efferent. So this branch provides the innervation to the lacrimal glands, 3 salivary glands, submandibular and sublinguals, and then we have the mucous membrane of the nasal cavity, hard and soft palates. The final one is the branchial branch, which is of course the second pharyngeal arch, muscles of the second pharyngeal arch during the embryonic development. That's what it provides innervation to. So this branch provides the innervation to the muscles of the facial expression, eyelid movements, and closing of the orbicularis oculi muscles, movement and closing of the mouth via the orbicularis oris muscles, the precise adjustment of the auditory ossicles via stapedius muscle, movement of the mandible via the mentalis muscle, and the posterior belly of the digastric muscle and innervation of the stylohyoid muscle. Now let's look at some clinical relations of the facial nerve. So one major clinical relation is the Bell's palsy. The damage to the facial nerve can lead to this difficulty in controlling of the facial muscle and abnormal taste. So especially if the facial nerve is involved, the sweet taste is not going to be functional. Signs and symptoms, so that include the weakness and paralysis of the facial muscles, drooling, drooping of the lower eyelid, sensitivity to the sound, and that is hyperacusis, and includes the impairment or loss of the taste, especially the sweets. Treatment include the antiviral agents. So the last nerve that we're going to look at is the cranial nerve number 8, which is vestibulocochlear nerve. The name is suggestive of what branches it has. So there's two different branches, vestibular nerve and the cochlear nerve. Functional component, only one functional component to this, and that is the special afferent, which will convey the hearing and balance. Vestibulocochlear nerve will exit the skull via the internal auditory meatus. So vestibular nerve, which is the first branch of the vestibulocochlear nerve, it will convey the sensory innervation to the vestibule and the semicircular canals, and this will relay the information regarding the spatial position and the motion, and this is critical for maintaining the balance. The second one is the cochlear portion of the vestibulocochlear nerve, and it provides the sensory innervation to the organ of the corti, which will convert the sound waves into the neural signals within the cochlea, and hence it is very critical when it comes down to hearing. Now let's look at some clinical relevations. The damage to this nerve will cause the tinnitus, most common symptoms, deafness, balance loss, and nystagmus. Causes, of course, tumor, infarction, drugs, and infections. The most important disease, which is a high yield disease for your USMLE exam number 1 or step 1, is the acoustic neuroma, and it is a benign tumor of the Schwann cells that involve the cranial nerves within the cranium. And it is most frequently involved or affects the vestibular branch of the vestibulocochlear nerve. Just remember vestibular portion of the vestibulocochlear nerve, and often present with hearing loss and tinnitus. The treatment is through surgical resections. This is the final slide of this presentation. In the next presentation, I will come up with the final portion of the cranial nerve, and we're going to discuss the other branches which are left in this. Thank you so much for following, and I'll see you soon.